Now we'll move to the second speaker, our professor, Dr. Tarek Mamoun. Uh, he will give us a presentation about beyond the capsule scalar fixation IOL as a savior technique. Please, Dr. Tarek.
Thank you, Dr. Faiz. Now we are going to discuss a situation that we face very common. You find a totally lost capsule after you finish the phaco, and you did not prepare any replacement retropupillary or any other alternative. And financially, sometimes the patient or the medical insurance does not pay for expensive lenses or something like that. So let's see this case. This is a limousine driver, 52 years old, previously myope, and he suddenly developed loss of vision and without any history of trauma. I found that his lens is totally subluxated like that. So how we are going to remove this lens, this is a problem, and how we are going to implant an IOL, this is another problem. So in this case, I decided to go for a very, very simple technique. At first, I prepared a tunnel without entering the anterior chamber. Then I made 3-port vitrectomy. Of course, this lens is going to fall down into the vitreous, and this is very, very good site to remove the lenses. Vitrectomy for dropped lens matter is not difficult. So we remove this lens from the posterior segment. This is not a difficult technique. And it helps to prevent any injury to the iris and the cornea. So removing the lens matter from the posterior segment is safe. After removing the whole lens matter, we examined the periphery and shaved the vitreous base. After that, we completed our 6.5 millimeter incision, and we marked the 3 and 9 o'clock positions. This is a very important step, to take a suture in the middle of the incision. Now we prepared the 6-0 Prolene sutures. This is the 9 o'clock position, and this is the 3 o'clock. Each one will go to the side of one side of the middle suture. So the suture in the middle of the wound helps to prevent intermingling both sutures together. Now we are implanting the PMMA IOL. We will pass these threads through the positioning holes, and we make flanges. And we have to be sure that these flanges are not smaller than the holes. Some IOLs have large holes, so that flanges will not be stable. So you have to test it before you implant. After that, you just implant the lens, cut the 6-0 Prolene, and flange it into the suitable position. And finally, you close your case, and this is the case at the end. This is the first day post-operative with very quiet eye and very good vision. So what are the golden rules or tips that make your life easy during this maneuver, Canabrava suture techniques? Number one, you have to mark the positions exactly 100 degrees from each other. Then you have to choose very thin insulin needle, 27 gauge, and 6-0 Prolene. I tried it once with 5-0 Prolene, and it was a very thick suture and annoying. So 6-0 Prolene is much better. Then divide the wound by 10-0 suture in the middle of this wound. This will help you in two important things. Number one, it gives you some tension during penetrating the globe, and prevents intermingling of the right and left sutures together. This is very important because it happens a lot during this technique. and take long pass of the needle through the sclera. Also, in order to make good flange, you have to dry the prolene. Don't heat it up while it is wet, because it will not flange in a good way. And use electric cautery with new batteries. Every case I place new batteries, because I don't like any bad surprises that the cautery is not working. So use good new batteries every time. And make sure that the flanges at the IOL tested before you implant, and make small flanges at the scleral side in order to facilitate burying these flanges under the conjunctiva and even through the scleral tunnel. And thank you very much.
Dr. Tarek, for this nice presentation and marvelous case. But I have some questions for you. What to do if the posterior capsule is totally lost and there is no budget for expensive IOLs?
This is what I do. This is not expensive. This is the PMMA IOL. It is less than 200 pounds, and the Prolene suture is not expensive. The only limitation is the availability of the diathermy, of the cautery. In this case, we heat up any hook, squint hook, to do the case, but this is, I don't like this mess in this operating theater. I prefer to have the electric cautery.
And did you try this technique with the hydrophobic IOLs, like if you will implant a premium IOL or any hydrophobic like aspheric or aspheric IOL, like the
No.
available in the market?
No, I did not try this technique.
Yeah. Even with the fenestrated two haptics, like the Mickey Mouse haptics or something like this, you can do it?
With the Gore-Tex
Yeah.
sutures. This is very good technique. If these lenses, if these IOLs are available, you may use it. But sometimes the Gore-Tex is not available in every operating theater.
Okay. And this IOL will ensure the stability of the IOL in these
Very,
fluid-filled
very
eyes?
stable.
No tilt, no...
No, I did not face any case of tilt.
Okay. Do you have any tips or tricks to avoid the tilt of the
providing
IOL?
that you have removed all the vitreous from the anterior segment. If the IOL is tilting, check there is a remaining vitreous in the anterior chamber, or remnants of the capsule, so remove everything.
Okay. And this incision will induce a lot of astigmatism?
No, it's a scleral tunnel. This is my beloved incision. It takes a little time. It is not difficult at all. And actually, I'm gradually abandoning the limbal incision. All the extracapsular cases, I do it through the scleral tunnel, almost zero astigmatism.
Okay. Any question from the panel, Dr. Tarek? Okay. Thank you, Dr. Tarek, for your nice and informative presentation.